I was going to talk about radiotherapy, radiation oncology, and prostate cancer. And Jürgen had already talked a little bit about prostate cancer in his talk this morning. He gave quite a good presentation about, particularly about PSA screening, which is a topic that's important in the general practice world. But I'm assuming you also have some patients who then have established prostate cancer and have to have some treatment. I've got a number of recent topical areas to cover with you. We have some terrible terms in radiotherapy which I'll have to try and explain. Hypofractionation means the use of a relatively small number of fractions. Over a course of treatment, we have a number of small treatments. Each of those is called a fraction. And we've been in the process of reducing the number of those, so that's referred to as hypofractionation. And that's been enabled by being able to make the treatment more accurate. We weren't able to give a series of bigger treatments before because the treatment wasn't accurate enough, and a big treatment is more toxic. So we've only been able to give these smaller number of larger treatments because of some technological improvements, particularly fiducial markers and the gel spacer, which I'll explain to you. And that's allowed us to reduce the number of fractions from about 40 to about 20, from about 8 weeks to 4 weeks. And we've been doing that now for 4 or 5 years, so you might have seen patients coming through who have had that sort of style treatment. And the next improvement that's going to be made, we've just treated our first couple of patients with SABR. And SABR, because of some additional technological improvements again, we've been able to reduce the treatment further from 20 down to just 5 treatments. So which makes it much more user-friendly for the patients. And I'll explain all about that. We've also been able to give a little bit of a boost treatment within the prostate to the area where the cancer seems to be most concentrated. Last time I gave a talk, I was asked to talk a bit about, sorry, my thumb's over it, protons. Protons we still don't have available in many places in Australia, and there's still no evidence to show that they're better than any other treatment. So it's an enormously expensive machine, about $100 million to set up a proton machine, so we won't be doing that. LDR brachytherapy, we were able to do that until recently, but we found there just wasn't a big enough demand to warrant maintaining the changes in the upgrading of the equipment and the training of the staff. So we no longer do that, and we think we've got other alternatives that we can offer in place of that. And PSMA PET scanning. So the PET scan that's particular to prostate cancer is a PSMA PET scan. And with the advent of PSMA PET scanning, we've been able to identify patients who have a relatively small number of metastases. So if you have metastases, you might only have a few of them. And that's a condition known as the oligometastatic state. And in that condition, there are some new treatments available. So the situation with prostate cancer hasn't changed a huge amount over the last couple of years, but it's still a condition that affects many thousands of men. It's a common cancer of the various types of cancer. It's a common one, and people often think of it as a cancer that men die of rather than die with. But in fact, quite a lot of men die of it. Over 3,000 a year die of it. So it's quite a common cause of death, as well as just being something that you live with. But having said that, we get quite a high percentage of patients surviving a long time. So there are a large number of patients who are living with cancer. And that's why it's important to treat it. I suggest that we're not only trying to reduce the number of deaths from prostate cancer, we're also trying to reduce the number of patients who have to live with the effects of the cancer and the effects of the treatment. So radiation therapy or surgery, which is the better treatment. Jürgen earlier today said that surgery was the gold standard treatment, and that's always a red rag to a bull with us. You've probably heard us argue about that before. But there is only one properly conducted randomized trial, which is this trial, the PROTECT trial. It's relatively recent. It was published about 5 years ago, but it does have 10-year outcomes, which means that the treatments were all done 10 years ago, so they predate a lot of the advances that we now have in both of our treatments. These are the results, and it's a bit of a busy slide, so I'll go straight to the important bits. So the patients were divided into either active monitoring, about 500 patients, surgery or radiotherapy, same number in each group. And these are the deaths over the 10 years. 4 deaths in the radiotherapy arm, 5 deaths in the surgery arm, and 8 deaths in the active monitoring arm. So there isn't a clear winner between the two in that parameter. So you could say that maybe saying that the surgery is the gold standard. The gold standard is to make available all of the reasonably available treatments that a patient could consider having, including radiotherapy. And looking further down the table, the number of men with clinical progression, which means progression in terms of your PSA levels or any other evidence of disease, 46, 46. So really no difference between surgery and radiotherapy, and 112 in those who had active surveillance, as you would expect, and many of those patients who then got progression on surveillance then went on to have active treatment. Our standard machine for many years has been the linear accelerator, but it has advanced. This is what it was like when I joined the practice in '95. And this is not, as well as being a snazzier photograph with a lot of extra lighting and so on. There are lots of extra technology that has been incorporated, and a lot of the technology is actually in the software, which I'll explain to you. But are these real advances? I mean, X-rays are X-rays. You can't really change X-rays. They're all over the universe. But what we have been able to change is the way that we manipulate X-rays to treat the cancer and not the patient. And a fairly fundamental advance occurred 5 or 6 years ago, which is VMAT, another one of our painful abbreviations that we use. And I thought that was a good question when you asked about VFI. You asked what that means. I had no idea. I had NFI what VFI means. But VMAT means that when you're lying on the table, the treatment machine rotates right around your body in an arc and then back the other way. And then as it's rotating, it gives us effectively a series of small beams at every possible angle. And as the machine is rotating around, the opening where the beam comes out is continuously changing size and shape, and the strength of the beam and the time it takes to go through that section of the arc is all being adjusted to optimize so that we get a strong dose right where the prostate is, as little as possible on the bladder, which is the yellow bit in front, or the bowel, which is the grey bit at the back. And if there is any extra dose, it has to go anywhere. It splashes out into areas where it's not going to do any harm, such as out here into the buttock where a low dose is being given. In hypofractionation, there's been a significant improvement on that because it has allowed us to reduce the number of fractions from 37 or 39 down to about 20, or to exactly 20. And several large trials have shown that it's safe to do that. It hasn't improved the oncology survival rates, but it has shown that we can do that, make that transition safely now that we have a couple of technological advances. We still have to treat patients that have positive pelvic lymph nodes with a large area, and because of that we can't hypofractionate them. They still have to have a full course of 8-week treatment, but we can hypofractionate those where we're just treating the prostate itself. And the main advantage of that, it's a lower cost because the charges are issued on a per fraction basis, at least to some degree, and greater convenience, particularly for patients that have to travel a long way. And I know that some of your patients travel from Grafton and out here and Bow Desert and other places, and it's steadily being adopted, and we'll talk about the technological advances that have made that possible. So the first is that VMAT has enabled us to produce a very conformal, a dose that conforms very well to the prostate. So the prostate is here in red. We expect it to move a little bit, so we allow a margin around it, and you might be able to see a little white dot there. That's a fiducial marker, and that enables us to zoom in on the prostate more accurately before each treatment. And you might appreciate a little bit of a slightly darker grey material in between the prostate and the bowel, and that's a gel spacer separating the two. So these are the fiducial markers. So on an X-ray they look like little white dots. They're actually made out of they're supposed to be a small grain of rice, the same size as a small rice grain. They're made out of gold, and patients always ask, well, can I get it out afterwards? And the answer is don't bother, because it's not a particularly high quality gold. It's not worth getting out. But you can see the size of it compared to a match head. We get the urologist to put 3 of them in, and we get them to put 3 in a different plane from each direction. So no matter which direction we're looking at the prostate from, they never lie on top of each other. We want to be able to see all 3. And the surgeons at John Flint Hospital have been very good at achieving that. And they also put in this spacer. 2 or 3 years ago we were using a product called SABR, and now we've upgraded that to a new product called Barry Gel. You don't actually see the writing on it in the CT scan, but when we became aware that that advance had occurred, we made it available to the urologists so they could start putting it in, and they all agree it's a much better product to use because you get a much more even placement of the Barry Gel to separate the prostate and the bowel more evenly. And it pushes the bowel backwards away from the prostate by about 1 centimetre, so that then moves the bowel, or at least the front part of the bowel, out of the really high dose area. It does require a procedure to put the fiducial markers in. It's a procedure similar to the biopsy, except instead of taking 20 or 30 pieces out, they just put these 3 little fiducial markers and the Barry Gel in. So it's generally a very safe and simple day procedure. And the gel and the fiducial markers have enabled us to improve the accuracy and the safety of the treatment, providing the treatment, each fraction doesn't take too long to give. And that was a limitation for us because we wanted to compress the treatment further from 20 fractions down to a smaller number, but then each fraction becomes quite large and starts taking quite a significant amount of time, and there's a possibility that the prostate can move during those few minutes that the treatment is actually being delivered. And it wasn't until we had this new technology that we have now that has enabled us to compress it further down to 5 treatments. And that's known as stereotactic ablative body radiotherapy, SABR, another abbreviation. But that has enabled us to reduce the number of fractions down to 5. Each fraction takes 3 or 4 minutes. We still use fiducial markers and Barry Gel, which account for the movement that might occur between one fraction and another. But in order to account for the movement that occurs during those few minutes, we now have this process called triggered imaging. So triggered imaging means that when the patient's on the table and the beam is going around, as well as being given the treatment from one direction, we're also taking images from the other direction. And we're watching those images live. Every 40 or 50 degrees that the machine goes around its arc, we take an image, and the machine can then detect on that image the position of the markers and make sure that the markers are where we would expect them to be if we were looking from that angle, and can tell us if the markers are out of position or not. So we can then, if they are out of position, and I'll show you that sometimes they can be, then the beam stops, we can readjust the position of the patient and restart the beam. But it also involves some other steps in making the treatment more accurate. It involves a vacuum bag. I'll show you what that means. It involves using a planning MRI. So in the process of planning for the treatment, the patient has an MRI to more accurately see exactly where the boundary of the prostate is, where the markers are, and where the gel is. And all of the plans that we do are reviewed by a committee to make sure that we're all in agreement on exactly what's prostate and what's cancer and what isn't. So this is a vacuum bag. It's a bit like a mattress, made a bit like a bean bag. So the patient gets nestled into the bean bag, the air is sucked out of it, it then forms tightly around the patient, and that then becomes the patient's own bean bag for the duration of their treatment. As well as the bean bag, we also have bladder filling and bowel emptying protocols. So the filling of the bladder and the emptying of the bowel have quite a significant effect on the position of the prostate. So we have to spend a few days before the treatment training the patient on how to fill their bladder, have it reasonably full at the time they have their planning and treatment, how to have their bowel empty, and they're usually pretty good at doing that. Intrafraction motion monitoring. So several years ago, a number of teams around the world did studies to check just how much the prostate moves, and they did that by, instead of putting in fiducial markers, they put in little radio frequency transmitters. So they put those into the prostate in the same positions as we would the markers, and then monitored their frequency, their transmission continuously, and it enabled them to determine movement of the prostate in the 3 directions, up and down, backwards and forwards, and side to side. And a lot of the time, over time, there isn't a lot of movement of the prostate, but there are some movements that can occur. For example, you can see here the yellow line is gradually transitioning upwards, which is drift over time, and that can occur if the bladder is just gradually filling during those few minutes. And you can see that. You can also see occasionally some quite sudden large movements of the prostate, even several millimeters, which is probably gas and contents moving around in the bowel if there's a peristalsis. And the same patient can be quite different from one fraction to another. So this is the same patient on consecutive days. So hardly any movement this day, all over the place that day. So just highlighting the importance of monitoring the movement. And this is a slightly speeded up version of what's really happening in all of our bodies at any one time. So the prostate is the dark grey bit in the green, and we think it moves about as far as that red line. That's done by an MRI scanner. And these are the fiducia markers showing up. This is what an X-ray would look like without fiducia markers. With fiducia markers, you can just see the white dots, and the machine works out the green circles. And if one of the white dots is outside the green circle, it becomes a red circle, and the machine stops. This is the amount by which you can see, or you sometimes see, the movement occurring. It's about 5 millimeters, or can be as much as 5 millimeters in all directions, and particularly in the anterior-posterior direction. And that has enabled us to, understanding those principles, has enabled us to reduce the margin that we allow around the prostate. So instead of treating the prostate plus a centimetre or so, we can treat the prostate in just a few millimetres. And you might not think that makes much difference, but even a small difference in the outer perimeter of a shape makes a big difference to the volume. And some clever person worked this out with an orange. You can see that the skin of the orange actually makes up almost the same volume as the orange itself, even though the skin is only a few millimetres thick. Although there are some air spaces in there. The orange is probably nicer to eat. There are still some limitations. The motion can only be checked at fixed time points every few seconds during the fraction. It can only be detected in 2 dimensions, so we can only see it if it's moving this way and that way. We can't necessarily see it if it's moving that way until a machine goes around there and looks at it. And we still have to take into account the urethra, a sensitive organ right in the middle of the prostate, which is responsible for some of the side effects. And we still are only able to detect motion as a shift and not deformity of the prostate, because the prostate does actually deform slightly. Not all patients are suitable for SABR. The patients that we're aiming to apply it to are those where we can treat the prostate with a fairly tight margin, minimising the dose to the other tissues. So we don't really want there to be any risk of cancer being at the margin. So if you have a high-risk cancer, very aggressive cancer coming to the capsule, into the tissues around the prostate, that patient's probably not suitable. So it's more suitable for patients who have relatively low risk or low intermediate risk disease. And those are patients that have other options. They have the option of active surveillance or surgery, but hopefully this will be appealing to them as well. Also patients that have artificial hips, it's hard to get such good dosimetry especially if there are 2 artificial hips. It's not impossible in terms of conventional hypofractionated treatment, but we're a bit shy about doing that for SABR treatment. There are a number of large trials and a lot of patients treated outside clinical trials with SABR now described around the world, and there's been a big combination of all their results into a meta-analysis. And this is their biochemical failure rate. So gradually some of the patients will get recurrence of their cancer, and that shows up as a rise in their PSA level. We refer to that as biochemical failure. Over a 10-year period, a small percentage get that. Small percentages get gastrointestinal and genitourinary toxicity, high enough to be considered grade 3, so it's quite significant toxicity, but fortunately only a small percentage. Not that different to other types of treatment that are being done. And these are the 2 main trials that have been done, the Hypo-RT trial and the PACE-B trial, showing that there wasn't really any difference in survival or in side effects comparing the SABR treatment with the hypofractionated treatment. The other advance to mention to you is the Flame, which you saw in the title of the book. And the term flame comes from the title of this trial. Trials often have big long names which are full of complicated words, and to make it simple and to encourage people to be recruited into the trial, so we can always remember there's a trial running and put the patients in, there's always an abbreviation, and these Dutchmen abbreviated this big long name to Flame. But looking at it, I'm not 100% sure how they got those letters, but anyway, somehow they got the word flame out of that big long name. And with the word flame, what it means is that as well as treating the prostate, which is the red circle, they've identified from the MRI scan that the cancer is mainly where that little blue circle is. Because with the advent of multiparametric MRI, MP-MRI, we can see within the prostate a lot more clearly than we used to be able to. So we can see that's probably where the cancer is. And that's borne out by studies that compare the MRI appearances with the pathology reports after a prostatectomy. So as well as treating the whole prostate, we then are adding a boost to that small area. So that little bit gets an extra dose. And we can do that providing it's in a favourable position, if it's not too close to the bowel or to the urethra or anything sensitive. So you might see us, in our letters back to you, reporting about the treatments that we've given, you might see us mentioning a boost. And this is their results from that trial. They studied overall survival and biochemical disease-free survival, and with the addition of the boost, they found the higher rates on that red line to that blue line. So at this point here, 7 or 8 years, the recurrences are about half what they would have been. So that's quite a significant improvement. Oligometastases, so that's the scenario where a patient has got recurrent disease in the form of metastases, but there's only a few of them, only 5. So that's what oligo means. And radiotherapy can have a role to play in patients with oligometastases, and we can now play that role using SABR. So here's a patient who was 63 when he had his prostatectomy 13 years ago. His PSA level fell to 0 and then rose to 2, suggesting recurrent disease. He was started on hormone therapy. At that time we didn't have PET scans, so we couldn't see where the recurrence was. On hormone treatment, his PSA level fell to nearly 0, but then in 2014 it rose again. And here it is rising over time. He then underwent a PSMA PET scan, which identified recurrent disease close to the prostate bed, where the prostate had originally been, behind the bladder and in several lymph nodes. And we were then able to use VMAT to treat those 5 areas all at once with quite a strong dose, 60 gram 30 fractions. So it's not SABR, that's conventional fractionation. And his PSA level went back down again, 0.5, 0.1, and so it's indicating a good response to that treatment, and it was very well tolerated. Here's another example. So a patient who's got a solitary focus of disease just in the vertebral body, and we're able to apply SABR to a vertebral body, sparing the spinal cord, so you can see the doses wrapping in a sort of a concave U shape around the cord, because the cord's quite sensitive to treatment. And he achieved a good result as well. And this is a patient who had a solitary metastasis just in the iliac wing, the wing of the ileum. So he was able to receive a treatment by SABR just to that small area without treating any of the adjacent bowel and bladder and other organs. So just summarising all that, and thanks for your patience so far, by the way, and feel free to sing out if you have any questions. We suggest that our outcomes are comparable to those that are achieved by surgery, and both treatments are gradually getting better, and that's to be encouraged, of course, but they're still relatively similar in terms of their outcomes, so there's no clear winner as to which is the better treatment. Hyperfractionation has enabled shorter courses, and selected cases can now be treated with SABR. To a higher dose can be given to small areas within the prostate. That's where the flame comes in. And that's been enabled by a lot of technological improvements. So thanks very much to all of you for listening. Please let me know if you have any questions. Even if they're not anything to do with any of this, just radiotherapy related. Yep.
The gel spacer, does that then stay forever kind of thing?
It sets over a period of hours, and then that gradually redissolves again over a period of months.
With the radiotherapy, how do you save the nerves?
When we're
effective are you prevention?
the
Nerve damage.
nerves usually aren't a big issue for radiotherapy. They're relatively resistant to nerves. In the case of SABR, because we're treating the prostate so narrowly, we're not treating the major nerves. We do tend to cause long-term effects on other tissues, on the urethra and the bowel and the pudendal vessels, which then can have an impact on erectile function.
If you're looking at surgery compared to radiotherapy with regards to erectile dysfunction,
Yeah.
which is the better outcome?
The PROTECT trial, they looked at sexual function in 4 different ways. All 4 ways showed radiotherapy slightly better. Likewise, urinary function.
Is it your opinion that all people that have prostate cancer should have a consultation with a radiotherapist at the same time? Is that what your views?
I think if they're considering definitive treatment, if they're considering radical surgery, then they should probably see us as well and make sure they... And the urologists at Jonathan Hospital are quite good at arranging that. We don't have a lot of patients going through not having that and then regretting the chance, but you might come across them in your practice.
That's my experience as well. Is that most of the time, as the patients with a clear preference, they will consult with both. But the question is, we should just be active in that referral at the time of new diagnosis, like with prostate cancer. The results come to me. You're going to see a urologist tomorrow. Would you like to see Dr. Christie the day after? I'll make a phone call. Get that organized, or wait until you've had the appointment with the urologist, let him, or trust that he will organize it.
Well, I think the GP can play quite a good role in that as a sort of a referee. And if the patient seems to be having trouble deciding, then I'll often suggest to them that they go and discuss it with the GP as well if they want another opinion. We also have a prostate nurse who contacts all the patients with the new diagnoses of prostate cancer. So she was supposed to be here this weekend actually, but couldn't make it. But she's playing a more and more significant role in helping patients decide and get information they need and get their appointments organised and so on.
What degree of immune suppression would this cause?
Only a little bit, because most of the bone marrow in a person's body isn't being affected by the radiation. So you don't see the profound neutropenia and so on that you might get with chemotherapy. But I do think the patients get a little bit run down. They're a little bit more prone to coughs and colds, but they're not seriously compromised.
I'm actually asking this in the context of COVID treatment. For patients who catch COVID and are undergoing procedures such as this, in terms of qualifying for the COVID medication.
Yeah. So patients do ask about that, and I've usually written back to the GP to say, well, it does have this mild effect. Whether or not that qualifies them or not is really between you as the person. I would say probably not myself, but I don't want to interfere with that discussion you're having.
On a practical, the markers, do they affect the MRIs later on?
No.
They still have MRIs?
Yeah. In fact, more and more patients are having MRIs as a routine as part of their preparation.
You mentioned brachytherapy is no longer on the Gold Coast. Is that still a good treatment, and should we be considering it for Brisbane, which actually still on there?
Yeah, it's still available in other places, and it's still a very good treatment. It has advantages and disadvantages, and some of the patients have been on the internet and decided that that's the treatment for them and that's what they want to have. And that's a perfectly reasonable decision for them to make.
It's available in Brisbane?
I think it is through Green Slopes, but I'm not 100% sure about that. But we just had such small numbers, and I think partly that was because of the cost of it. No other questions? Well, thanks very much for listening, for your stamina getting through a big day. Thank you.